radial angiography, Dr. Raj Pal Chand will take 15 minutes to give us an overview of the radial artery angiograms. Thank you.
So, good afternoon everybody. I thank the organizers for giving me this opportunity, and especially Dr. Srinivas. So over the next 15 minutes, we will briefly go through the basics of transradial angiography. It's very important to know that what is the basic difference between an angiogram performed the transradial route and the transfemoral route. There are multiple issues which are different, which will begin from the puncture. What are the issues that occur during the actual access, that is from the wrist to the forearm and to the ostium, and what is the catheter selection and how we go about this. So since there are many points, I will just go through over the next 15 minutes what actually catheters we use and how the catheter selection is made and how we go about this. Basically, an angiogram is done, to have good visualization of the coronary tree, it's important to deliver an adequate volume of contrast, and the catheters that we use must be easy to use, they must be atraumatic, and they must remain stable during the entire procedure. This is very important. A catheter that gets kicked back very quickly, especially when you're doing a transradial procedure, no use because you can't keep changing catheters, and you should not be spending too much time in the transradial route. So the three catheters that we generally use are the Amplats catheter, the Tiger or a brachial catheter. The Tiger catheter and the brachial type catheter are actually the same. They are just labeled differently and given to different institutions. They are exactly the same catheter. And the third catheter is the Judkins type catheters. So it's important for a radial operator to be familiar with all these three catheters because they complement each other wonderfully. In each lab will have its own workhorse catheter. In our lab, the Amplats catheter is the workhorse catheter for all transradial procedures. So the transradial catheter is a single end hole catheter, and this I would say it's one of its biggest advantages. It seats very well. The Amplats catheter, once when it is seated in the coronary ostium, it gives excellent support, and you actually need not worry about this catheter being pushed back. And the advantage, another advantage of a single Amplats catheter completes the right and left coronary injections. However, the problem with the Amplats catheter is it is definitely a little more technically demanding, and one has to be familiar with this catheter before one embarks and proceeds to do this on a regular basis. The second thing is there is certainly a higher risk of dissection, especially in the right coronary artery. There is a very small but finite risk of dissection, and so one has to be familiar and be very careful and keep this in mind. Another particular problem is that occasionally you can have poor opacification of the left anterior descending. See, the Amplats catheter prefers to go into the circumflex, and therefore in a small number of people with a large dominant circumflex, you can have your catheter going into the circumflex and with suboptimal opacification of the left anterior descending artery. The other problem is that when the ascending aorta are short, you may not be able to swing the Amplats catheter from the left coronary ostium to the right coronary ostium. It may be difficult, and the entire catheter can just buckle in the aorta, and therefore these are the problems with this catheter. So the second catheter which we use often is the brachial type or the Tiger catheter. This is an end hole catheter with one side hole. There is only one side hole for this catheter. Again, the advantages are, I think the most important advantage is that it's a catheter which is very, very easy to use. And so again, single catheter completes angiography. There's a potential to perform LV angiogram with this catheter with a hand shot. And it's a catheter which is very easy to use. And So the most important thing is, and it's the catheter of choice in patients with aortic stenosis. In aortic stenosis, an Amplats catheter would be difficult to manipulate because it's an active manipulation. You got to go into the coronary, into the sinus, and then actively manipulate it into the left coronary ostium. Whereas a brachial type of catheter, the manipulation is much more passive, and the jet will permit you to will not disturb the manipulation as in an Amplats catheter. And it's also useful in patients with a short ascending aorta. So you see, again, the most important disadvantage of a Tiger or a brachial type catheter is it has two holes. So the side hole can, look at pressure, and you can be actually injecting through the end hole into a patient, into a plaque, and you don't get this warning of wedging or ventricularization. So I believe this is the most important disadvantage of the brachial catheter. And another problem is it tends to kick back. We will just look at the mechanics of this catheter and you'll know why it tends to kick back. I mean, all of us would have had this experience that the brachial catheter tends to kick back, and you have to resync this catheter during angiography. Another thing is it has a very long tip. So, it tends to point upwards and cannulate the conus branch selectively, which is unlike a Judkins. So it's long tip. When you are looking at cannulating the right coronary artery, many times you inadvertently cannulate the conus artery, and then you have to do something else to get out. So if you look at this cartoon or this line diagram, you will see that if you look at this line diagram, you will clearly see that this is the Amplats. Figure A refers to the Amplats. Is this line diagram clear, or are they doing something there? Okay, if you could, can you see this? Yeah. So if you look at this carefully, if you look at the picture A, this is an Amplats catheter. This Amplats catheter actually, why does it get such excellent support is, it sits on the floor of the aorta, number one. Two is, it takes support from a more of the ascending aorta, a little more of the ascending aorta is involved in its support. And the third and most important thing is, when you inject contrast, the terminal few millimeters of the Amplats catheter is not perpendicular or is not actually in line with the force that you use to inject. For example, if you use a gun and you shoot, the recoil is maximum when it's perpendicular to the contrast. So if contrast is injected like this, the recoil is exactly perpendicular, exactly in line with this, and the terminal few millimeters of the catheter is not in line with the recoil, so it doesn't get kicked out. So for example, if you look at the Tiger catheter, first of all, its support is much more in the arch and the distal part of the ascending aorta, and you have the terminal end of the catheter is actually in line with the recoil force. So once you inject contrast, the recoil force is what tends to kick this catheter back. So very, very frequently you get the catheter needs to be repositioned during coronary angiography when you are using a Tiger catheter. So this is very important to understand, and then you know that this is why this recoil occurs and how to deal with this. Now you know that this occurs. So there is something called a procedure of building and then blasting, which means that you would begin your injection little slowly and then give a final push when you notice that the catheter is continuously being kicked back. Such a problem would never occur during the Amplats catheter, or very, very unusually. However, the Tiger catheter has one very nice advantage, and this advantage is that the commonest anomaly of the coronary tree is the origin of the right coronary artery from the posterior sinus. So this is very, very easily cannulated by the Tiger catheter. What you do is, once you see that the right coronary ostium is not in its usual place, you just go back to the left cannulate the left or go very close to the left with the Tiger catheter, rotate anticlockwise a little, and almost always you are definitively seated in the posteriorly arising right coronary artery. This is the most common anomaly, and this is very, very easily cannulated transradial with this catheter. So this is a line diagram, again a cartoon to show you how the Tiger catheter has a longer tip and on many times always cannulates the conus artery. This is an inherent problem with the use of the Tiger catheter. So what do we do about it? You have two options. One is to go off plane. Whenever you cannulate an ostium, you always want to be in plane or coaxial because that traumatizes the coronary ostium less. So you want to go off plane, which will rotate it anti-clockwise. And during your LAO projections, you will see that the terminal tip actually looks shorter. That means you have gone off plane. And when you go off plane, you come out of the conus and you remain in the main body of the right coronary artery, and you can continue to inject like this and quickly finish off. The second way to deal with this is ask the patient to take a deep breath, and the entire right coronary artery will descend, and your catheter from the conus will slip into the main body. The second thing is to use a little wire above, which we will get to later. So when you use an Amplats catheter, which the normal size, the workhorse catheter will be an AL2, and if the patient is short, you can use an AL1, less than 150 centimeters. If the patient is more than 170 centimeters, you can use an AL3. Now, what about the Judkins? So we have looked at the Amplats, we have looked at the brachial type catheters. What about the Judkins? The Judkins catheters are only catheters which are used for special niche situations when you have the left radial approach, or when you have the left radial, of course, you could use the Judkins left and right. It would mean an additional exchange. But most importantly, the Judkins is used to complete an angiogram. The Judkins right is used for a non-dominant. When the Amplats will not get into a non-dominant right coronary artery, you use a Judkins right. Or when the brachial is not cannulating it, you use the Judkins right. So it's important to keep in mind doing an angiogram why it is important to be familiar with all these three catheters. The AL, the brachial or Tiger, and the Judkins they complement each other very well. So for selective LAD cannulation, the brachial is much better. For selective circumflex visualization, the Amplats is better. So the weakness of the brachial is the strength of the AL and vice versa. A short ascending aorta, it's very difficult to get the Amplats to swing into the right coronary artery. So at that time, the brachial is a good choice here. Aortic stenosis, catheter of choice is brachial because it would seat well. Embarking on a transradial program, the best catheter to start with is the brachial. The Amplats offers excellent stability and best visualization of the coronary artery tree. So it's important to see how these all go together. Now, you also have another maneuver called the free-floating Amplats maneuver. This is when you have an undersized AL. Many times, you really don't measure the height of the patient, or the technician gives you a catheter and you find you're running short, or your AL2 does not actually reach the ostium. So what maneuver? You perform the free-floating Amplats maneuver. This is when you have taken an undersized AL and you're not reaching the ostium, or you're just reaching it. So what you do is you ask the patient to take a deep breath, hold, continue to push, and at which time you just about reach the left LCA ostium after the heart and diaphragm descends, because you get additional length. At that time, what you do is, when you're just reaching the ostium, you gently withdraw the catheter, rotate a bit, and the Amplats, which was actually sitting on the floor of the aortic root, now floats upwards and cannulates the right coronary, the left LCA ostium very well. So this is again a line diagram to just show you this. This is the AL2 or the AL which is undersized, not reached the ostium. You ask the patient to take a deep breath. Some of these gentle curves at the arch clear up. You get additional length. You just about cannulate. When the patient is holding his breath in deep inspiration. But this patient cannot be holding his breath during inspiration for the entire procedure. So at that time, so immediately when this occurs, you have to rotate the catheter a little clockwise and actually pull back the catheter. And what happens is the Amplats, which was sitting on the floor of the aorta, now becomes a free-floating Amplats, and it cannulates the vessel very, very well. Believe me, this happens very commonly, and this is a wonderful way of dealing with the problem. And this maneuver is called the free-floating Amplats maneuver. So if you look at this, you will see this is the way to do it. So if you look at the catheter, it is still not floating. You're not reaching. Just when you reach, you turn it clockwise, and when it reaches, you just turn it clockwise and pull back. Actually, you are able to reach and cannulate this ostium. This is something which is done quite frequently. The other technique, the last technique which I will be describing, is the Hardened Technique, wherein you use a catheter, use the stiff end of an 035 wire to cannulate a vessel. So this is again this is an XBLAD, it could be even a diagnostic catheter. At one point you keep pushing from the radial, through the radial approach, and you have a loop upstairs, you keep on pushing, you're just going to get buckle this catheter more and more. So what you do is just pass the stiff end of a wire up to its primary curve, and immediately you are able to cannulate this vessel, and then you set out to what you're doing. The last example would be for when you look at this is a diagnostic catheter. When it hooks up like this, if you continue to push, when it hooks, the Amplats hooks, it will only continue to hook. So if you push this catheter down, if you push a hardened wire down, then you will be able to cannulate this. So certain precautions are there when you use this type. Be careful not to exit or traumatize the coronary tree when you exit with the stiff end of the wire. And it's also most important is to empty your catheter of contrast. If you have contrast and then you push the hard on the wire, you will not see the end of the wire. So make sure your diagnostic catheter is free of contrast before you actually use this technique. Thank you for your patient listening.